going to talk about really the role of imaging in the diagnosis and staging of pancreatic adenocarcinoma, but also we're going to define some terms. So I hope everyone can have a similar vocabulary at the end of the day today. I have no relevant disclosures. I have material and support from some companies. But this is a quote to guide the talk. I took a quote from the NCCN guidelines. And it says, decisions about diagnostic management and resectability should involve a multidisciplinary consultation at a high-volume center with the use of appropriate imaging studies. Okay, the reason why that's important is that a lot of decision-making and a lot of the art of the decision-making needs to be done with people with many years of experience. So we're going to talk about some diagnostic management, imaging staging, and we'll go over a couple quick cases. Okay, so if you have a patient has some abdominal pain or is coming through the ED and they get a CT, which is probably the most frequent way of diagnosing these things, they'll have a routine CAT scan. Okay, and a routine CAT scan can sometimes misdiagnose and definitely misstage a pancreatic adenocarcinoma in up to 50% of the patients. So what you really need is if your patient, if you suspect pancreatic cancer or your friend had a pancreatic, they say, oh, I might have pancreatic cancer, is make sure they get a very simple term, a pancreatic protocol imaging study. So that's a protocol with different phases of contrast to make sure that we're really outlining the tumor and staging it appropriately. Okay, and you can see here that this is a CAT scan with contrast. There's contrast in the aorta there. This is the kidneys, contrast in the aorta, the portal vein, and artery. And here is the same patient a couple seconds later. Okay, and the phases of contrast will show us as you can see here, this is a severe pancreatic duct dilatation, but you can see the pancreatic parenchyma hyperenhancing. And then here, you can see the veins are all enhancing throughout. And that delineation will show the hypoenhancing, hypoattenuating pancreatic cancer in the background of the hyperenhancing pancreatic parenchyma. It'll also show us delineate further venous anatomy on this phase and also potentially describe any possible metastatic disease to the liver. MRI is another modality that can be used. Just to tell everyone the difference between CT and MRI is that CT is much better at spatial resolution. However, MRI is much better at conspicuity, so seeing the difference between two soft tissue planes. Currently, MRI is mainly used to further characterize or potentially screen for small pancreatic lesions. However, it does have a promise of better defining some of the hazy perivascular findings we see on CT, which, as you'll hear about in a couple minutes, really defines the stage of these tumors. So a general pancreatic CT is 80% predictable for resectability. And that is good because as a tool that we're currently using, because it allows more people to go to surgery, and that allows more people to get a definitive treatment. I'm not saying they need to do the Whipple during the surgery, but it allows people to get to the surgical evaluation. So in terms of reporting this, so in terms of having the same language, the blueback speller of pancreatic adenocarcinoma for the multidisciplinary committee was set in, the most recent one is January 2014, Society of Abdominal Imaging, and it essentially outlined a template which was literature and high-volume institutions supported that programmatically stages and anatomically evaluates patients with pancreatic adenocarcinoma. Okay, and after the use of this template was then evaluated, and the people that use the and the referring physicians that use it, the referring physicians communicate to the radiologists that the template provides a superior evaluation and confidence in these patients' evaluations. So here's just a brief outline of that template. It essentially breaks down evaluation of a possible pancreatic adenocarcinoma into a morphologic, evaluating the arteries and vessels, and extra pancreatic disease, okay? And within the morphology, it tells you the size, the type of enhancement, if there's any secondary findings, such as pancreatic ductal dilatation. In terms of the artery, it tells you where in the artery it is, what arteries it's surrounding, and other things, the amount of percent contact with the artery, if there's any artery or vessel or any vessel irregularity or thrombus, and also anatomic variants. So image grading and stages. So now we're taking this adenocarcinoma and we're figuring out where is it going to fit into the treatment algorithm. So there's stage 1 and 2, which are resectable. Stage 3, which we'll spend some more time on throughout the day because that's the gray zone of treatment. And then stage 4, which is metastatic disease. So here you can see tumor grading. So a tumor grade of 1 is less than 2 centimeters with clear pancreas around it. Tumor grade of 2 is greater than 2 centimeters, again, clear pancreas around it. Tumor grade of 3 is essentially any size extending beyond the pancreas but not involving the vessels. And then T4 is somehow involving the vessels. And so we bump that up and we take it to the stage. So a stage 1 is either a T1 or T2. So you're saying it's either less than or greater than 2, no nodes and vessels, no nodes involved, no vessels, and no extension beyond the pancreas. And then we take it to stage A, which is, again, it's a T3, so it's extending beyond the pancreas, but no nodes and no vessels. And then a stage 2B, which is less than 2, greater than 2, or extending, but it does have lymphadenopathy and no vessels. We'll talk about the lymphadenopathy again right here. So lymphadenopathy in pancreatic cancer is defined by what lymph nodes are resected for either a Whipple or a distal pancreatectomy. Lymph nodes that might be involved outside of a standard of care for your institution dissection plane so lymph nodes outside of those dissection areas it's considered metastatic disease. And I'm sure the surgeons will talk more about that. So, so the big distinction between all of these stages, so stage 1, stage 2B, and 2A, is that no vessels are involved. So let's talk about when vessels are involved. So stage 3, all of a sudden the tumor is getting close to touching or intimately involved with either the SMV or the veins around the pancreas or the arteries that are around the pancreas. It can be any lymphadenopathy, but again, not M nodes, and so not nodes that are outside the resection area. That's considered metastatic in this, this definition. So stage 3 then has 2 kind of described categories. There's the borderline resectable and the locally advanced disease. So the borderline resectable is borderline resectable. It means a surgeon thinks that they could get it out. The locally advanced disease means that there's probably more vascular involvement and that they probably cannot surgically remove it. So, and these are broadly defined terminology, and because the terminology is not language of report precision, it means that certain institutions will interpret that in different ways. So that's why this is the gray zone of resection. So let's go back to the blue-back speller. So these are how the society wants to define the terms. And so someone gets a CAT scan, they see an artery, they see the tumor is next to the artery. This is how the report needs to be dictated. So if they say abutment, and that means that the tumor is involving less than half the vessel. If they say encasement, it means the tumor is involving greater than 180 degrees of the vessel. And then there's also a descriptor term called deformity, which means there is solid tumor intimately involved next to the vessel, and there is irregularity within the lumen of the vessel. And as you move across here, it suggests a higher degree of vessel invasion. And that's for an artery, and they did the same, almost the same exact thing with veins. So abutment is less than 180 degrees, encasement is greater than 100 degrees. And then there's this term called deformity again, and that could be extrinsic compression on one side, extrinsic compression on two sides, or another unique imaging finding on a vein is called the teardrop deformity. And essentially that is a lot of these tumors produce scar tissue, and that is the tumor is essentially pulling in a little bit of the vein, and it suggests a higher degree again of vessel invasion. So again, we're talking about now criteria for arterial resectability, borderline versus locally advanced. And so these different groups have defined the degree of vessel involvement in different ways. So the NCCN guidelines say that the celiac axis, the celiac artery, at the head, no abutment, okay? At the tail, abutment's okay. It's probably because the surgeons that want to follow these guidelines think they can get out the whole artery with an R0 margin, so no microscopic tumor even left behind. And for that common hepatic artery, all the different groups agree, abutment or short segment encasement allowing for resection. So the surgeon can remove a part of that artery and it'll be okay. And again, SMA, they all agree that, encasement, so greater than 180 degrees, that's not going to allow for surgery, but abutment might allow for surgery in those cases. One of the reasons why the SMA is there's so much agreement is that the SMA also has a lot of lymphatics involved around it, and so the morbidity is higher if they need to resect the SMA. And so the SMV, essentially, they did the same thing. Here, the vein is theoretically more easily reconstructed, so people are more willing to take the risk with encased vessels. This is just, again, risk stratification for vessel involvement. You can see that unilateral involvement has less of a risk of vessel invasion than complete occlusion. Here's just a case showing a replaced right hepatic artery off of the SMA right there, and you can see that this vessel right here is very irregular. So that's complete encasement of a right replaced hepatic artery, and that was not, as it was locally advanced. There was no metastatic disease, but it was unable to be reconstructed, so they were unable to perform surgery. Here's a case. This is a dilated common bile duct here, and this is the portal going down to SMV, and you can see here a little teardrop deformity, and this is actually not the common bile duct anymore. This is the hypo-enhancing, hypo-attenuating pancreatic adenocarcinoma. And so that was able to be reconstructed with an R0 resection. And so moving beyond this, there's a balance between diagnostic and therapeutic. Diagnostic, we need to be able to better define, better utilize non-invasive detection of micro and macroscopic tumor extent, such as MRI in the hazy gray zone around the SMV and SMA, and therapeutic decisions such as neoadjuvant chemotherapies, external beam radiation, and I'll talk for 30 seconds on about IRreversible electroporation. It's an ablation technique that essentially electrocutes the cells, causing extracellular fluid shifts and death. And it does not disrupt any parenchymal or any supportive structures. So here's an adenocarcinoma around the celiac axis. Here are 2 probes. And immediately afterwards, the vessels are still patent. And theoretically, in this situation, the tumor is dead. This patient also had neoadjuvant therapy and chemoradiation with an R0 resection. So that's it.